Welcome to the Center for Experiential Learning Faculty Development course for simulation-based training. We have developed 5 modules that cover the basics of simulation-based training. These include how to perform a needs assessment, developing goals and objectives, writing simulation scenarios, implementing simulation-based training, debriefing simulation-based training, and assessing simulation-based training. Following completion of the 5 modules, you will attend a one-day course focused on implementation and debriefing of simulation-based training. In this first module, we are going to talk about why we use simulation and how to perform a needs assessment. Most industries that have the risk of losing lives or valuable assets have adopted simulation as part of their basic operations. Military and commercial aviation utilize a wide variety of flight simulators, and in fact, commercial aviation invests 10% of its operating budget in simulation training. Nuclear power plants in the United States utilize 1 week of every 6 for training in nuclear power simulators on critical scenarios, and financial planning utilizes computer-based simulations called Monte Carlo simulations. What about healthcare? Many healthcare providers will state that they practice all the time, but in fact, daily work is not deliberate practice. Deliberate practice focuses on the skills we aren't able to do well or even to do at all. In our daily work, we can't take the same risks that would occur with deliberate practice in a simulated setting. And as well, in our daily work, feedback or coaching is frequently missing. Our patients are more complex and more ill than in years past. Our healthcare providers have less hands-on experience. Residents are working under work-hour restrictions, and new nurses typically have had less clinical experience than in years past. Once students have graduated from professional school, there's limited time dedicated to hands-on training and, again, deliberate practice. Simulation is a bridge between the classroom and real-life clinical experience. In simulation-based training, learners have the freedom to make mistakes and to learn from them without consequences to patients. The learning experience can be customized. We can accommodate a range of learners from novices to experts, and beginners can gain confidence and muscle memory by performing these tasks, again, in a low-risk environment. There are some complex procedures and rare conditions that simply do not present often enough to provide opportunities for practice, even to clinicians that have been practicing for a substantial period of time. For example, malignant hypothermia is a rare but critical condition that anesthesiologists and the operating room team need to be able to manage when it occurs, but an anesthesiologist could practice an entire career and never actually see a case of malignant hyperthermia. Now we have a short video clip. This is from the 2006 film The Guardian about the training of Coast Guard rescue swimmers. In this particular video clip, the Coast Guard rescue swimmers are involved in a simulation to understand the effects of hypothermia.
First stages, hypothermia is the most critical. Why? Because you still have the ability to think. Say it. The decisions you make during this stage are going to determine whether you live or die. Is there a reason you're not breathing, goldfish? Is there a reason why you're not breathing?
I don't know anyone who can stay alive without breathing for 15 minutes, Eugene.
Are you a coroner? Because pronouncing people dead is not part of our job description. What do we always say? We never stop, Jake. Not from the cabin to the tarmac. We never stop.
Aye, Senior Chief.
Understood? Yes, Chief. Okay, Jake, in the swole. Hodge, you're up. You're with the dummy. All right, now. 3 letters. 3 letters will get you people a cup of hot coffee and a blanket. What do you say, Goldfish?
Actually, not that cold anymore, Senior Chief.
You're not cold anymore because blood is moving from your outer extremities to your heart. That's why your arms won't work. You can plan on spending roughly 60% of your career in a mildly hypothermic state.
Senior Chief, may I have a word? Why wasn't I informed of this? You know, we have classrooms. And your assignment is to simply teach the stages of hypothermia.
Sir, in about 2.5 minutes, they'll understand. Permission to carry on, sir? Go ahead.
Again, simulation education is a bridge between the classroom and real-life clinical experience. One of the unique features of simulation-based training is the debriefing or after-action review. Typically, during real clinical emergencies, the pace of operations does not allow us to do a detailed review and learn about why things took place and how to improve performance. But simulation-based training should be immediately followed by debriefings or after-action reviews that detail what happened. In addition, advanced surgical and task simulators can provide information concerning the adequacy of cardiac compressions, placement of endotracheal tubes, adequacy of ventilation is through data that is collected during the simulation itself. This data enables us to provide more accurate feedback and target necessary improvements. One of the advantages of simulation-based training is it moves the steep part of the learning curve away from the patient. We know that when learners are learning a new technical skill or procedural skill, there is often a slow beginning and then a rapid acceleration in learning that terminates in proficiency, followed by a plateau. By using simulation-based training, we move the steep part of the learning curve, the dangerous part of the learning curve, away from the patient. Simulations also allow for the opportunity for the deliberate practice of a variety of non-technical skills or communication and teamwork skills. These include things like asking clarifying questions, using assertive statements, shared mental models, as well as high risk and infrequent scenarios. We mentioned deliberate practice earlier. And again, to reiterate, the goal of mastery learning is to ensure that all learners accomplish the educational objectives to a high degree of proficiency. The time needed to reach mastery standards varies among learners. So this training is not time-based, but actually based on mastery or proficiency of the particular skill that is being trained. When we think about simulation and competencies, we can think about technical competencies, which may be individual or team, non-technical competencies, which are the communication and teamwork skills. And these can be for the individual as well as for the team. And then we can also think about system competencies. Does the system allow for and provide the resources that are necessary for the team to perform successfully? In 2009, Barsick and McGahey published a study on mastery learning in central line placement. The study was an observational study that took place in 2 ICUs. One was a medical ICU and the other was a surgical ICU. In both ICUs, the baseline rate of central line infections was similar. The intervention was that residents in the medical ICU were trained to mastery on central line trainers to a high degree of proficiency. Both ICUs started with the same rate of central line infections, but after the intervention, the medical ICU dropped to 0.5 central line infections per 1,000 catheter days, while the surgical ICU actually increased to greater than 5 central line infections per 1,000 catheter days. In addition to just the change in rate, there was a $700,000 net savings in the MICU, and 12.2 days in the MICU were saved per central line infection. In simulation-based training, we can also focus on non-technical skills. Non-technical skills are designed to train team members how to achieve maximum mission effectiveness in a time-constrained environment under stress. This definition by Kern was originally used to describe non-technical skills in aviation, but it applies equally well to healthcare. Which of the following is a technical skill? Closed loop communication, chest tube placement, sharing a mental model, or assigning roles and responsibilities? The answer is chest tube placement. It's a technical procedural skill. Simulation has been found to enhance clinical competence at the undergraduate and postgraduate levels. It's also been found to have many advantages that can improve patient safety and reduce healthcare costs through the improvement of healthcare workers' technical and non-technical competencies. Over the last 20 years, a variety of manuscripts have been published that demonstrate improvements in procedural skills, non-technical skills, as well as team performance related to simulation-based training. Although many people thought simulation-based training intuitively made sense, we now have evidence to support that assumption. We also know that simulation is a tool to enhance adaptive capacity. Improvements in team performance, system, and environment allow us to decrease the attention we pay to those particular elements, and it allows for improved adaptive capacity and increased margin for maneuver of both the frontline healthcare provider and the team. Which of the following is a non-technical skill? Endotracheal intubation, central line placement, using a person's name or role when making a request, or performing CPR? The directed request is a non-technical skill. Rather than speaking to the air, using a person's name or their role, such as respiratory, allows us to gain the attention of the person that we are asking to complete a task. When we consider simulation-based training, we begin with a needs assessment. A needs assessment can be described as a systematic process of gathering data, a gap analysis, part of the pre-planning stages of an activity. It also establishes the need for the educational activity. The needs assessment is the initial step in developing simulation-based training. The needs assessment involves the identification of a target audience, who are our learners, and an assessment of the target audience's needs. The learning objectives should relate to those needs, and the choice of simulation should address those needs and the learning objectives. Another way to think about a needs assessment is by identifying the gap between a current state and the desired state. To perform a needs assessment, we need to provide the foundational evidence of the need for well-designed simulation-based training. The required elements may include an underlying cause of concern, for example, a root cause analysis or a gap analysis, an organizational analysis, for example, a SWOT analysis, surveys of stakeholders, learners, clinicians, and educators, outcome data from pilot testing, previous simulation-based training, or aggregate healthcare data, and standards. For example, certain certifying bodies require certain types of competencies. One example would be the Fundamentals of Laparoscopic Training course that is required for all surgical residents to graduate from their residency. A needs assessment may be an iterative process. For example, a problem is identified, a lack of knowledge, skill, or practice is identified as a cause of the problem. Is the problem amenable to an educational intervention? And if so, what are the best educational tools to use to address the problem? Ways to collect the data could include surveying stakeholders, soliciting input from stakeholders. These include the learners, as well as the people that work with the learners in the healthcare setting, collecting quality improvement or performance improvement data, collecting summative evaluation data from previous activities, as well as trends in literature, law, and healthcare. A needs assessment should include both perceived and unperceived needs for all simulation-based training. Perceived needs include those which the learner is aware of. For example, I know that I don't know how to suture. I know that I don't know how to administer adenosine. Unperceived needs are those which the learner is unaware of. The learner may not recognize that he or she does not possess or is not able to perform certain skills which will be required of the learner. Both sets of needs are important to identify for the purpose of instructional design, as well as planning the session. Oftentimes, multiple sources of information are needed to triangulate in order to develop appropriate simulation-based training. When we think about the needs assessment, we can think about normative needs, the standards that are accepted for a particular course of training. And these include professional bodies like a board of practice or a college. These can include the kinds of skills that are necessary for certification or licensing. There can be prescribed needs that relate to deficiencies in the current educational program, and for example, program directors or faculty development or professional development educators may identify those. There can be perceived needs, what the students think they want to learn, as well as expressed needs, what the students say they want to learn. And these may be similar, but may not be. There can be needs of two different groups compared to one another. And then the unperceived needs, what learners don't know and that they need to know. In addition, another way to think about a needs assessment is in terms of a system. In recent years, in situ simulation, simulation that occurs in the clinical environment, has been used as a way to understand the strengths and weaknesses of certain systems in terms of critical events. In situ simulations can be used to probe a system, to identify latent threats, identify knowledge gaps, identify challenges around accessing equipment, and to understand the patient experience. This type of simulation can also be used to understand adverse events, complications, as well as staff retention and satisfaction. Translational simulation, or simulation that does occur in the clinical environment, is also important for understanding culture and improving interfaces, handovers between teams, as well as understanding how well guidelines, pathways, and protocols are functioning, and how closely they reflect work is done. When we conduct a needs assessment, we often have several kinds of data to assess or to analyze. There may be service data, survey data. We may have input from various stakeholders. There may be data from quality improvement initiatives or quality dashboards of a particular microsystem, macro system, or the healthcare system altogether. There may be summative evaluations from previous activities, as well as trends in literature, law, or healthcare. As I mentioned previously, oftentimes this data needs to be triangulated to understand the whole. What seems to be the underlying reason for the problem or the gap? The needs assessment is a critical aspect of developing simulation-based training, but often receives short shrift. In fact, doing an appropriate needs assessment is critical to understanding what are the skills that need to be trained. As we use the data to identify or confirm, validate a gap, we want to understand the difference between the state of what is the current state and the desirable or achievable state. Is the gap due to knowledge? Is it due to skills? Or is it due to practice? Inability to show or to do in practice. Miller's model of clinical competence differentiates the learner who knows, has knowledge, knows how, is able to apply the knowledge, and is able to show how or does, when the learner is actually able to apply the knowledge and skills in a simulated setting or the practice environment. The simulated setting is showing how, and the practice environment is doing. Which of the following is not part of a needs assessment? Baseline skill or knowledge of learners, availability of simulators and task trainers, stakeholder input or survey, standards and practice guidelines. The availability of simulators and task trainers is not part of the needs assessment. It will be part of the educational planning, but is not part of identifying the gap or deficiency in skills or knowledge of the learners. This is an example of a gap analysis worksheet. It shows the desired state, the current state, what has been identified as the gap, and is the gap due to a lack of knowledge, lack of skills, or an inability to show or to do? What's the purpose of identifying this particular gap and improving it? And what is the outcome measure that will demonstrate we've achieved or closed that gap? For example, if we have a pediatric patient in respiratory distress who's placed on a non-rebreather face mask support that's applied appropriately within 5 minutes of presentation, and that this occurs reliably 100% of the time, this is the desired state. In the current state, the stakeholders have identified that the patient may be placed on a non-rebreather mask, but the face mask is not applied appropriately. The identified gap is a skill in applying the non-rebreather face mask to a pediatric patient in respiratory distress. The gap is due to a lack of skill in applying the non-rebreather face mask. The purpose is that the registered nurses in the emergency department will be able to apply a non-rebreather face mask correctly to all pediatric patients in respiratory distress. And the outcome measure is a successful return demonstration of a non-rebreather face mask for patients in respiratory distress. The participants, the learners, must correctly assess the signs and symptoms of respiratory distress and apply the non-rebreather face mask correctly with a high degree of reliability and accuracy. Now, we'd like you to think about 3 methods you would use to conduct a needs assessment for your learners. Think about a gap that you have identified in your own system, who the focused group is, who are the learners, what is the desired state, what's the current state, and what is the gap, and what is it due to? And how are 3 methods that you will use to conduct a needs assessment for your learners? Thank you for your attention. Now we'll move on to the next module, goals and objectives.